Hi all, thanks for coming. So the presentation is actually just on the surgeon costs rather than the system costs. The paper is on the system, but thank you for allowing me to present today. So gastric bypass has a steep learning curve and is a complicated procedure. Adverse outcomes are generally associated with increased costs, complications being one of the most important drivers of increased costs. These costs or costs associated with the learning curve have not been previously characterized. This work stems from previous work that was recently published in Annals that our group did. What we looked at was surgeons over the first 600 procedures and looked at the risk of complication over the first 600 procedures. And what we found is that there was a general downward trend in that. And if you compared the same surgeon after their 450th procedure to their first 75 procedures, you found essentially a half or a complication rate that was halved after all adjustments. And so you saw this, and this was one of the first longitudinal or long-term studies of learning curve, as most of them stop at about 100 to 150 cases, so a lot of them don't go past. And so our next step was to look at, well, what's the cost associated with this learning curve? If surgeons get better over time, is there a cost that's associated with it? So this study, our hypothesis, or the study sought to quantify the effect of cumulative procedure volume on inpatient cost and characterize excess costs associated with the surgeon's learning curve. So we took all adult patients who underwent gastric bypass in Ontario, Canada from April 2009 and March 2015 who met NIH criteria. Just to clarify, Ontario is one of the only jurisdictions in the world where gastric bypass is the main procedure. In fact, approximately 90% of procedures that are done bariatric are gastric bypass rather than sleeve gastrectomy. This is just how the system kind of developed. So sleeve is only done for super obese as part of a two-stage procedure, those IBD or other contraindications to gastric bypass. The Ontario Bariatric Network specifically was set up in 2009 and is unique because it started all at the same time at 7 different sites. And so it's a large-scale regionalized surgical care system with accreditation standards. One of the accreditation standards, or one of the important ones for surgeons, is that all the surgeons in our study are high volume, at least 50 cases per year anyway, and they're all fellowship-trained surgeons. So when they were looking for surgeons to establish the Ontario Bariatric Network, these were it. Of note, there are no other hospitals in Ontario outside of the Ontario Bariatric Network that provide bariatric surgery. So it's a regionalized care system. You're only allowed to do bariatric surgery in Ontario at these hospitals. So our data is from our main administrative database in Canada, rather than like a NISQIP clinical database. So that's the Canadian Institute for Health Information Discharge Abstract Database. Data was received at the provider level, and we also had the dates and times for each procedure, so we were able to quantify the cumulative volume. Patients were identified using ICD-10 codes and CCI codes. The main outcome of interest was the inpatient cost during the index admission. This was standardized to 2014 Canadian dollars, which now is about 70 cents on the dollar, 75 cents anyway. So the costing methodology is a standard one used by the administrative database and has been standardized and validated over time by our administrative database. It includes all in-hospital costs, including operating costs, ward costs, nursing, administrative, essentially anything that's associated with it. What it does not include is physician remuneration. Of note, physician remuneration in Canada is essentially constant, and the billing code hasn't changed over the time period, so we didn't find it that important to find out the exact billing costs for each of these patients. The main predictor of interest was surgeon cumulative volume. Cumulative volume was analyzed in blocks of 25 cases. To ensure no misattribution of the system efficiency to surgeon cumulative volume, hospital cumulative volume was also included as a factor. So in other words, if the costs did go down over time, this wasn't attributed to, oh, well, everyone at the hospital had costs going down over time. It was the actual surgeon. So we adjusted for that. And so if we saw that there was actually, well, costs went down because everyone at the hospital had costs that went down, we would have been able to pick that up. In addition, adjustments were made for standard patient demographics, comorbidities, age, gender, normal comorbidities that we could get from an administrative database. Importantly, in addition, we also adjusted for annual surgeon volume and hospital volumes, just to make sure that it wasn't, well, it's the high volume surgeons or the low volume surgeons or this or that were associated with costs, but this was just, we tried to really isolate the surgeon experience part of it. Of note, once again, the lowest annual volumes were at least 50 per surgeon. So as far as the statistical analysis goes, we used a multi-level linear regression model. So I don't know if you're familiar with hierarchical regression models, but as random effects, we had a 3-level model. So we had patients within surgeons within hospitals. So once again, these models adjust for correlation within surgeon and hospital factors. So basically, it basically adjusts for that correlation. In addition, cost is not a normally distributed variable, and to adjust for that, we used a Bayesian analysis, or at least a Bayesian method of estimation, a Markov chain, which assumes no underlying distribution of the data, and you run it through a simulation of 100 to whatever, 100 to, we use 100,000, but you could do up to 1 million. There was no change, basically, over 100,000 times. Costs, as I said, are reported with 95% confidence intervals. We use Stata and ML-Win. So overall, during the time period, the 6 years from the start of the OBN to 2015, we identified 11,684 procedures performed by 29 surgeons at 9 centers of excellence. Compared to the first 25 cases, your 51st to 75th case conferred a decrease of $2,775. And what we found was that the savings, unlike the complication rate, which went down all the way to 400 or 600 cases, the savings were relatively stable after about case 50. And so this is basically the crux of the paper. These are actually unadjusted, but the adjusted analysis essentially mimics this. The solid line is the mean cost per patient, and on the x-axis, it's the surgical experience. So from your first case in the OBN to your 400th case. And what you see is, after analyzed in blocks of 25, after the 50th case, you see essentially a straight line all the way across. And this is one of the first long-term analyses of this type of curve or surgeon experience related to cost. In the paper, we also looked at the mean length of stay as well. And because cost and length of stay are very correlated in our system, just because a lot of the health costs are standardized. And so the mean length of stay, as you can see, it starts above 3 days, and then the average length of stay is around 2.5 days for gastric bypass, and that stays relatively stable over time. As per our previous study, you see that the complication rate's also highest during this phase, and after about 100 to 150 cases, it goes down to about 25% less. So when we ran our multivariable analysis, this is just the surgeon cumulative volume part of that. So these are adjusted costs. These are adjusted for patient factors, hospital factors, annual volume, all of the other things. And what we see is, and this is as kind of techie as I get when it comes to PowerPoint, is that you see that clear line of demarcation in the adjusted cost. So before the 50th case, you really see no difference in cost compared to the first 25. And after that, you see a relatively stable decrease in costs of about $2,500 less. So kind of as a post hoc analysis, what we did was when we found this phenomenon, we looked at every case after the 50th case and compared it to every case before the 50th case. And what we found, there was an average cost savings of around $2,000. And when you look at that, for the first 50 cases, what we estimated was the first 50 cases cost and excess system costs, when you compare basically one surgeon to themselves 50 cases later, of around $100,000. So basically bringing in a new surgeon into a system costs a system like in Ontario about $100,000 extra than if an experienced surgeon was doing that. So what does this mean? So first of all, there is a little element of regionalization in terms of cost, because the fewer number of surgeons you bring into the system, the fewer learning curves you have to deal with. What's more, and I think the more important aspect of the study, is there's a big economic incentive to train surgeons, even fellowship-trained, high-volume surgeons, in the first couple of cases to see if we can bring this down. So the idea of surgical coaching, even if it costs, as you can say, it costs about $100,000. So if, that creates an economic incentive that if it costs $10,000 or $20,000 or $30,000, if you can bring that rate, that complication rate down in the first 50 to 100 cases, you're going to save money. This is also, we're starting to embark on a bunch of different cases. Our next one's actually lap livers. And what we're looking at is basically this type of cost and this type of learning curves is really associated with almost every major surgery, Whipples and lap livers and all that stuff. And although the learning curve specifically will be a bit different for each of them. Anyway, thanks for listening.